eradication in cirrhotic versus non-cirrhotic patients. As an introduction, we know that there's around 70 to 170 million people who has hepatitis C across the world, and the burden of this disease is spread across the continent. We know with acute hepatitis C infection, with anybody who has hepatitis C, they will develop over hepatitis inflammation over the liver, and with chronic inflammation, the liver will progress to become fibrosis and cirrhosis, and subsequently they can develop into end-stage liver disease or hepatocellular carcinoma. This progress takes around 20 to 30 years and is not necessarily progressive. It can be accelerated by certain factors such as co-infection with hepatitis B, with HIV, fatty liver, and also with diabetes. Now, in May 2016, the World Health Assembly endorsed by the Global Health Sector Strategy on Viral Hepatitis, which proposes to eliminate viral hepatitis as a public threat by 2030. This will mean there will be a 90% reduction in new cases of chronic hepatitis B and C by 2030, and there will be also 65% reduction in hepatitis B and C death, and 80% of these people will be eligible for treatment by 2030. Let's look at our home, Malaysia, where we know there's around 450,000 patients were infected with viral hepatitis. And we will also know that our main genotype in Malaysia is genotype 3, around 50 to 60%, followed by genotype 1. Let's go with these two cases. Case 1, RM. RM is a 63-year-old female. She has no other medical illnesses. She was referred from the GP back in 2016 when he noted that he had an anti-HCV positive. She had a risk factor of being had blood transfusion during maternity time, and there was a hemoglobin of 14.1 gram on referral, platelet of 207, creatinine 66, ALT and AST are mildly elevated, and the GP said the ultrasound was normal. So you can appreciate that this is a normal case that you may see in your clinic from day-to-day basis. So let us just see who are the patients that needed screening for hepatitis C. Okay, so we know those patients who had blood transfusion or solid organ donation prior to 1989. This virus was found in 1989. So other risk factors, other patients who are high risk to be screened are persons who are ever incarcerated, persons with HIV infection, in particular SMM, children born to hepatitis C infected mothers, persons with percutaneous parenteral exposures in an unregulated setting, patients with sexual partners who are hepatitis C, and of course, if there's any unexplained chronic liver disease and or chronic hepatitis, including elevated ALT and AST. So when we screen our patients, what we do is actually sending for anti-HCV antibodies. This could be in rapid diagnostic tests or laboratory test immunoassays. Once we have the screening test is positive, anti-HCV, we need to confirm our hepatitis C viremia, and the two tests that we can do are basically HCV RNA, which is by the lower limit detection is 15 IU per mil. This is the most sensitive test that we can use, and there is another test, may not be as sensitive, such as HCV core antigen, where the lower limit of detection is around 500 to 3000 IU per mil. Of course, it's a slightly more cheaper test than HCV RNA. Once we have our HCV antigen positive, we can already start to treat this patient. We do not have to send for HCV RNA. So besides knowing the viremia of this patient, knowing that there is virus that we need to treat, we would like to know whether they are cirrhotic or non-cirrhotic. Liver biopsy is always the gold standard to determine evidence of cirrhosis, but it's rarely done now. for obvious reasons. It's invasive, it can cause mortality, it's staying in hospital for 2-3 days. So there are other methods that we can assess for evidence of cirrhosis, such as imaging, either ultrasound or CT scan, even MRI. And in some places, we can do transient elastography. If the reading is more than 12.5 kilopascal, denotes cirrhosis. And if you don't even have either, there are other biomarkers that can be used, such as EPRI score, FIT4 score, which are very good in negative predictive value. An EPRI score or a FIT4 score can be seen when you download it on your QX calculator in your smartphone. The EPRI score is mainly an AST over the ALT, upper limit of normal, divided by 100 times 100 divided by platelet count. So in case 1, the RM, 63 years old, who has hepatitis C, there is evidence of viremia. We have sent the HCV RNA, which is 1 million IU per mil. The ultrasound is normal. And if you calculate the EPRI score, it's 0.84. So in summary, RM has chronic hepatitis C, 1 million viral load. She is treatment naive, never been treated before, and there's no evidence of cirrhosis based on her platelet counts, which was more than 150,000. The ultrasound was smooth margin, and we had a fibroscan, which was 10.7 kilopascal. So you can look at these guidelines in treating hepatitis C. There's the EASL guidelines, that's 2018, and also the 2016 is what we're looking now because of the medications that we have. There is the American or the AASLD and the IDSA guidelines, and there's also the WHO guidelines. Our local setting, we have this management of chronic hepatitis C in adults, CPG, which is done by MATAS and Malaysian Health Technology Assessment Section, which was just published last year, and we can look it in the website. So what are the indications for treatment for hepatitis C? So all treatment naive and experienced patients with hepatitis C infection who are willing to be treated and who have no contraindications for treatment should be treated. So you can see this statement in all the guidelines that you read. What are the goals and endpoint? The goals of therapy is to cure hepatitis C infection in order to prevent the complications of hepatitis C, to improve the quality of life, and also to prevent onward transmission of hepatitis C. Our endpoint is SVR, which is sustained virological response, which is defined by undetectable HCV RNA in serum or plasma 12 weeks, which is SVR 12, or 24 weeks, SVR 24, after the end of therapy. That means you have completed your treatment and 12 weeks or 24 weeks later, which is assessed by a sensitive molecular method with a lower limit of detection of less than 15 IU per mil. So let's look at the evolution of antiviral therapy for hepatitis C. In the early days, in 1990, when the treatment came in, it was just using interferon. And the interferon success rate, the SVR rate, was very much lower, 10 to 20%. And in 1998, there was a combination of interferon and ribavirin, which has pushed up our success rate, SVR rate, to 30 to 40%. The interferon is taken 3 times a week, and subsequently the standard of care in early year 2000 was pegylated interferon, once a week interferon therapy, and ribavirin. It's been taken for 24 to 48 weeks. There's lots of side effect of interferon: fever, flu-like symptoms, hypothyroidism. Patients have to inject ribavirin with evidence of anemia, thrombocytopenia, and so forth. So newer treatment after 2011, there is an evolution of treatment with direct acting antivirals, which is a DAA, with the new tablets, which is more potent, improve the SVR rate at a much higher rate to 80-90%, easy to take, shorter duration, 12 to 24 weeks of treatment. So what are the drugs which are available for hepatitis C in Malaysia. So the first DAA which was available was the Vikirex-Xvira combination. And subsequently in 2015, sofosbuvir was in the market. Sofosbuvir needs to be used in combination with another agent. What we are using now is sofosbuvir and daclatasvir. Sofosbuvir initially is renally excreted, and thus using it in an end-stage kidney disease or CKD stage 4 and 5 would be a bit more cautious prior to starting this treatment. Subsequently, sofosbuvir Lavida combination 2-in-1 Harmony was in the market, and there's also Eplusa, and there's also Zepatier was in the market as well. But just to inform that Zepatier, Vikirex-Xvira, is no longer been marketed in Malaysia. They've stopped producing these two tablets. So sofosbuvir still plays a backbone in treatment of hepatitis C. If you look at the treatment recommendations for hepatitis C mono-infected, either hepatitis C alone or co-infected with HIV, now HIV are no longer considered a special population. The treatment and the success rate is more or less the same as monotherapy. In patients without cirrhosis, if you can appreciate this combination, as I was mentioning earlier, sofosbuvir and daclatasvir is the treatment that we use for most of our patients starting 2018. Whatever their genotype is, genotype 1A or 1B, 2, 3, 4, and 5, if they were treatment naive, you only need 12 weeks of therapy. So this RM was started on sofosbuvir and daclatasvir. She's treatment naive, she's non-cirrhotic for 12 weeks duration, starting 5th of March in 2018 and completed 27th of May in 2018. If you can appreciate, looking at her blood results, she was started here with a viral load of more than 1 million. She was actually my first patient. So upon 4 weeks upon starting, I've already tested her viral load, and it was not detected at this stage. There was no drop in hemoglobin. She did not need ribavirin at all, so there shouldn't be any problem about anemia throughout her treatment. The kidney function remains normal. She didn't have any comorbids, no renal impairment, and you can appreciate the liver enzymes when we started. It has plummeted down and has normalized since. So she completed her treatment in end of May, and 12 weeks upon completion, we reassessed the HCV RNA, and the HCV RNA was not detected, and she actually has achieved SVR. In other words, she has achieved cure. She's still on our follow-up once a year. Her blood test remains normal. So basically, the treatment is relatively easy to take. The follow-up is easy as well. All you need to do is at week 4, call them in just to assess for side effects, concurrent medications, send for full blood count, creatinine, ALT, and AST. That's all. And at week 12, prior to them completing it, just test them all again. And then 12 weeks upon completion, you want to send for HCV RNA to assess for SVR. If the hepatitis C RNA at 12 weeks post-treatment is not detected, you can say that she has achieved SVR, achieved cure, and she has no other liver comorbidities. You can discharge her home. Now let's look at case 2. Case 2 is slightly more difficult than case 1. So it's a 53-year-old man who is a previous IDU respecter. She has a background history of diabetes and hypertension, and she is on amlodipine and metformin, very common drugs that you see in your clinical setting. And he's done his hepatitis C viral load, which is 442,000 IU per mil. So her white cell count is around 7, hemoglobin is 14. You can appreciate the platelet count is a bit lower. Creatinine is 69. ALT and AST is slightly elevated. INR is 1.3. Ultrasound just says coarse echostructure, and you've done a fibroscan. You're a bit clever now from your first case. You've done a 14.2 kilopascal. which is cirrhotic, and you have done an EPRI score 3.2, anything above 2 is considered cirrhosis as well. So just to show for those of you who are not familiar with FibroScan, there's a small machine here. Patient lie down on the side. That's the probe that you used. It's quite reliable, non-invasive method for assessing FibroScan, but it's not widely available. And what you can look at the scoring card, just match to the disease, hepatitis C, anything more than 12.5, as denotes by the red color here, is cirrhotic. Green is not cirrhotic. So the patient was 14.5. So you can establish there's evidence of cirrhosis in RA. Once you know that the patient is cirrhosis, you would like to know their Charles Pugh score A, B, or C. We've known this from medical school days. Charles Pugh scoring, 2 clinical, 3 biochemical. You just give them a mark according to what you see. He wasn't encephalopathic. He has no ascites. The bilirubin was 30. Albumin was 38. Prothrombin time was normal, 1.3. So he got 5 marks, and 5 to 6 is a Charles A liver cirrhosis. So as a summary, RA, 53-year-old man, was diabetic and hypertensive on medications, has chronic hepatitis C, liver cirrhosis, Charles A. Now, when the patient is cirrhotic, it is still quite important for us to know the genotype, because that will tell us, prognosticate us on what treatment we need to use, whether she needs ribavirin on board or not. So there is 7 distinct genotypes and 67 subtypes. I've already mentioned on my third slide, majority of our patients are genotype 3, followed by genotype 1. If you look at the EASL guideline 2016, patients with cirrhosis, we're going to concentrate on this box, sofosbuvir and daclatasvir, the DAA which is available in Kementerian Kesihatan Malaysia. So you can see it varies slightly. If they are cirrhotic, if they are genotype 1, they only need 12 weeks. If they're treatment naive, they're treatment experienced, you can use 12 weeks with ribavirin or 24 weeks with no ribavirin. Genotype 1B, just 12 weeks, either they are treatment experienced or treatment naive. If they're genotype 3, whatever, if they're cirrhotic, either naive or experienced, you need 24 weeks with ribavirin. So you can appreciate on this chart, genotype in a cirrhotic patient plays a role to establish what sort of treatment parameters that we would need to give for our patients. Besides knowing that they are cirrhotic and the duration of treatment, RA had diabetic and hypertension on medications, amlodipine and metformin. So you will want to know whether our DAAs, sofosbuvir and daclatasvir and ribavirin, has any drug-drug interaction with our medication. So this is app, Liverpool chart, drug-drug interaction, which you can download again on your smartphone to look for this interaction. All you need to do is key in the medications that we are trying to give to our patient, sofosbuvir, daclatasvir, ribavirin, put in the co-medication that the patient is on, amlodipine and metformin, and you'll have and it will come out like this. Either they are in orange, red, or green. If there's green, there's no drug-drug interaction. It's safe to use these drugs on this patient. If there's a potential interaction, such as daclatasvir and amlodipine, what you need to do is actually either switch your amlodipine to something else, maybe perindopril, or gap the timing of this medication. If you're going to use your DAA, sofosbuvir and daclatasvir in the morning, you can tell their patients to take amlodipine at night. So these patients were started on DAA, sofosbuvir and daclatasvir for 24 weeks because he's cirrhotic, he's a genotype 3, and he needed ribavirin 1,200 milligrams daily. This is weight-based. Less than 75 kilos needs 1,000 milligram. He's around 80 kilos, he needs 1,200 milligram. And ribavirin is also teratogenic, so we have to tell him not to get pregnant, or tell him not to father a child during the treatment of course of this medication, and at least 6 months after. So these are the drugs that we use, sofosbuvir, daclatasvir, and in our case 2, RA needed ribavirin as he was cirrhotic. How do you monitor them? Well, if they are ribavirin, you need to monitor them a bit more closely. You need to see them as early as week 2. Look for evidence, look at the full blood count, creatinine, he's cirrhotic. So we did a bit more like bilirubin, INR, ALT, AST, and subsequently we would probably see them monthly after that. Week 4, week 8, week 12, week 16, week 20, and week 24 to complete the treatment. And at least 12 weeks upon completion, we would want to see the HCV RNA to assess SVR, to assess cure. So if you can appreciate his blood test, you can see the white cell count was normal. The hemoglobin, we started the medication here. 2 weeks later, you can already appreciate a drop in the hemoglobin to 12.6. So at this time, and further drop 2 weeks later to 11.5. At this stage, we have supplemented him with hematinics. So it was stable throughout. And upon completion in August, you see that once we stopped the ribavirin, as he completed, the hemoglobin bounced back up again. The platelet was slightly low but maintained. Creatinine was normal throughout. Again, the ALT and AST, upon starting as early as 2 weeks, has normalized and persisted to be normal. INR was not disturbed during those treatment course. At the start, he had 442,000 IU per mil. When he completed his treatment, and 12 weeks upon completion, HCV RNA was not detected. And again, this is by saying he has established SVR. How do we follow them up post-treatment? If they're non-cirrhotic, they achieve SVR, we can discharge them. If they have abnormal liver function tests, we want to evaluate for other causes, such as fatty liver, or reinfected with hepatitis C, or so forth. If they're cirrhotic and achieve SVR, because they're cirrhotic, we still need to have surveillance or HCC with a 6-monthly ultrasound and alpha-fetoprotein. We will want to do endoscopy for esophageal varicose surveillance. And if they're cirrhotic and no SVR, we want to monitor for progress of disease. We would like to retreat them with other combinations in the near future. And of course, these are the cases. Please refer to a tertiary center. So just to tell you about the benefits of treatment and cure, the curative treatment reduces risk of liver cancer by 75%, risk of all causes of mortality by 50%. Curative treatments improve cost effectiveness compared to past treatment regimens, patients' quality of life, health outcomes for individuals who are co-infected with HIV, and curative treatments prevents further transmission of hepatitis C infection. So in conclusion, screening and diagnosing hepatitis C is important to link to care. Treatment for hepatitis C is easy, affordable, and cost-effective. High SVR rates is seen in patients who have been treated with sofosbuvir and daclatasvir. It's important to check on drug-drug interaction. With that, I thank you.